afternoon, everyone, and welcome to today's Clinical Path Conference. We are honored to have with us Professor Puneet, a renowned GI surgeon from the Department of Surgery, Institute of Medical Sciences, Banaras Hindu University. Sir specializes in GI surgery and hepatopancreatic biliary surgery with a strong focus on both areas in his research. Professor Puneet has authored over 110 publications in prestigious national and international journals, along with 8 books and 14 book chapters. I would like to invite Professor Puneet to present the case.
Good afternoon, everyone. The faculty members of All India Institute of Medical Sciences, and probably few of the students are also there. I welcome them all to this CPC meeting. I'm honored that I've been invited by this institute to conduct this meeting. Now I'm going to present a case that is 49-year female resident of Mandoli, New Delhi, housewife by occupation, presented with a complaint of pain in the right lower abdomen for 9 years and constipation for the same duration. Patient was apparently asymptomatic 9 years back when she developed a pain in the right lower abdomen, which was on and off and was occurring 2 to 3 episodes every month. And this pain was non-radiating, dull aching, mild to moderate in intensity, which was aggravated after taking meals and lasting for 3 to 4 hours. Patient relieved with the pain after taking oral medication. Patient complains of pain which was aggravated for last 5 days. Patient also complains of constipation which was on and off, relieved after taking lactulose and sometimes progressed to non-passage of platters, and patient has not passed platters for last 3 days. Patient also complains of vomiting, which was on and off present for many years, and it usually occurs after the episode of constipation and abdominal distension. Patient has 2 episodes of vomiting in last 1 day, which contains a semi-digested food particles. Patient also complain of passage of black tarry stool occasionally in last few years and tenesmus for last 1 year. There is no history of fever, yellowish discoloration of eyes and urine, or severe abdominal pain which required hospitalization or IV medications. There is no history of chronic cough or hematemesis. Patient is known hypertensive and was on medication for last 4 years. Patient has received antitubercular treatment in 2022 for 7 months when she has been diagnosed as abdominal tuberculosis on imaging. Then after, the patient was kept on steroid for last 1 month for the suspicion of IBD. There is no history of medical comorbidities and there is no history of previous surgical intervention. Patient was taking mixed diet and having a normal appetite with normal bowel and bladder habits. Patient was para 4 and has last child 22 years ago. Patient was menopause for last 4 years. There is no similar complaints there in the family. On examination, the patient was well oriented to time, place, and person, well cautious, cooperative, average build, well nourished. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or fetal edema, and vitals were normal. On per abdomen examination, on inspection, the abdomen was flat, umbilicus was centrally placed, inverted, overlying skin was normal, there is no scar mark, no sinuses, dilated vein, or visible peristalsis or lump there, and all organs were moving proportionately with respiration. On palpation, no abnormality was detected. The abdomen was soft, non-tender, and there was no organomegaly or lump which was palpable. On percussion, the tympanic nodes were noted there in the central abdomen, and on auscultation, the hyperpulsatic bowel sounds were noted. Cardiovascular and respiratory system were within normal limit. So the case summary is that 49-year female housewife presented with a pain there in the right lower abdomen, which was on and off for past 9 years, which was associated with episode of abdominal distension and vomiting, and the pain got relief after taking oral medication with a history of antitubercular treatment for 7 months and steroid for last 1 month. Patient have pain got aggravated for last 5 days, which was associated with non-passage of flatus in stool for last 3 days and vomiting for last 1 day. Here is the X-ray chest, which showed no abnormality as such. Ultrasound, I am not able to read it off, which has been provided. I think the input will be given by my radiologist colleague, which are there. Now, this is the CT enterography, which has been performed, but shows a dilated bowel, what you can see here, with mural thickening. Along with, there's a homogeneous enhancement of the wall is present. Similar, you can see here also, there is a mural thickening along with the dilated loops with a homogeneous enhancement there of the wall. This is the CT clip. Which has been provided to me. You can see there is a dilated loop as it has been shown earlier with mural thickening, homogeneous enhancement, and there is a stricture at the terminal ileum with proximal dilated loops, what you can see here. There is a transition zone which has been seen here, and the dilated loops along with the mural thickening, what you can see here. There is a mesenteric congestion has been noted. However, there was no ascites. The colonoscopy was done, which was normal. During colonoscopy, 30 centimeter of the terminal ileum was also evaluated. The small bowel was evaluated through single balloon enteroscopy, in which the jejunum and the proximal ileum was evaluated up to 285 centimeter there from DJ. In laboratory investigation, the hemoglobin was 7.6 gram per cent. The TLC and the platelet counts along with the DLC was normal. The liver function test revealed no abnormality. Apart from the patient has low albumin, that is 2.6, and the fecal calprotectin was 340. It was raised. And the management, what has been done is the diagnostic laparoscopic followed by exploratory laparotomy with resection and anastomosis of the small bowel. So can I proceed with further, or you are going to have opinion? I should proceed here. So if we get a patient like this, the differential diagnosis which always comes to our mind is the tuberculosis of the small bowel or the Crohn's disease. Of course, we won't go with the imaging only, because if you see the imaging only without the history, we have other differential diagnoses like the lymphoma can also come in the differential diagnosis. But going with the history, I have made a diagnosis that it is a tuberculosis of the small bowel or the Crohn's disease. Now, it is very common to have these problems in our setups when we are not able to differentiate. Are we dealing with the Crohn's disease or intestinal tuberculosis? It's all because of the reasons. The Crohn's disease is very uncommon in our setups, and it is very difficult to have a diagnosis of Crohn's disease, particularly in an area like ours where the tuberculosis is also endemic. And it's all because of the reason of the poor sensitivity of the test for the diagnosis of intestinal tuberculosis. We all know that 10 to 15% of the intestinal tuberculosis, they are misdiagnosed as Crohn's disease. At the same time, 15 to 20% of the Crohn's disease, they are misdiagnosed as intestinal tuberculosis. So you can imagine that we have a difficulty in making or differentiating the two conditions. If this Crohn's disease, they are misdiagnosed and we start the ATT, it may lead to a progression of the disease, or it may also lead to other complication like a stricture. The stricture formation in a patient with Crohn's disease, if they are kept on ATT, is a bit high. It's all because of the reason, the fibrotic effect of the antitubercular drugs. If these patients, the ATT has been started, like patient with the Crohn's disease, ATT has been given, So you can appreciate that there is a decline in the inflammatory markers are there, and if we can assess these markers to have a diagnosis, we may be misleading. So what is recommended as such, that is the re-endoscopy. These patients, if they are cut on antitubercular drug, they should have a re-endoscopy done to have a proper evaluation of the response. In Indian studies, like the ASCA, which has been used for the diagnosis of Crohn's disease, it may not be effective in our setup. In intestinal tuberculosis, we all know that there is a segmental involvement is there, although the ileocecal region is most commonly involved. The rectum is rarely involved with the tuberculosis. So if these sites are involved, we can suspect that it is intestinal tuberculosis, not the Crohn's disease. However, if the patient have a small bowel involvement, if the patient have a proximal segment involvement of the small bowel or the multiple segment involvement, we suspect the patient is having a Crohn's disease rather than being intestinal tuberculosis. Now, I made a summary in which you can go to the article, and lot many articles which are available as such, but I have made a summary just to let you know exactly how we can differentiate the Crohn's with the intestinal tuberculosis. When we talk about the clinical presentation here, can you situate to the market, please? When we talk about the clinical presentations, what favors the Crohn's disease, that patient having a chronic disease which is present for months and years. The patient presented with diarrhea, hematochezia, that is bleed per rectum, or if they are associated perianal abnormalities like a fistula, they may have a fissure, or extraintestinal manifestations they are present, we suspect that the patient is suffering from Crohn's disease. At the same time, if the shorter history is there, the short duration of history is there, or if the patient have associated pulmonary or peritoneal symptoms, like the pulmonary symptoms, we know that is cough and hemoptysis, and the peritoneal, you can say, involvement in the form of ascites or lump. If these are suspected, then if these are present, one may suspect that the patient is suffering from intestinal tuberculosis. When we talk about the imaging, what favors the Crohn's disease, that is the mural stratification. What happens? There is a mural thickening with a layering effect, what we call it as a mural stratification, that is very characteristic of a Crohn's disease. Apart from that, for fibrofatty infiltration, the Coombs sign. Coombs sign is nothing but a hyper enhancement of the mesentery. Eccentric involvement of the stricture, all these are long segment involvement is there, that is more than 3 segments they are involved, particularly there for the colon, and there is a high visceral fat to subcutaneous fat density or ratio has been seen, that it is a case of a Crohn's disease. At the same time, if the necrotic nodes are there, concentric stricture, short segment involvement, ascites, peritoneal omental involvement is present with low visceral fat and subcutaneous fat ratio, then it is in favor of intestinal tuberculosis. Now, on colonoscopy, it is very important to know exactly how we can differentiate the two conditions. If you suspect the patient is having a Crohn's disease, it is a longitudinal ulcers which are present with skip areas and cobblestoning, along with anorectal pathology. If it is an intestinal tuberculosis, the patient have a transverse or circumferential ulcers. They are present, patulous ileocecal wall, and it is a short segment involvement, that is less than 4 segments they are involved. I think histology will be covered by my, you can say, pathological colleagues. Now, we all know that the tubercular granuloma, they are large granuloma, they are not small granuloma, they are confluent, dense, and they are located in submucosa, and they may be characterized by central causation. However, the granulomas of the Crohn's disease, they are small, that we call it as microgranulomas, that are discrete and ill-defined. So this is the last slide where I can enumerate how we should approach to a case where we have a dilemma whether the patient is having a Crohn's disease or tuberculosis. The first thing is the history, the endoscopy, the histology. I think it will be covering here in the last. The tuberculin test, the interferon gamma release assay, CT enterography which has been done in this patient, and there are certain validated scores are available. That is the scoring system which has been prescribed by a few of the studies. The scoring based on the imaging, scoring based on the endoscopic finding. Those findings, those scoring system may be used, and based on that we try to differentiate. But if the dilemma still persists, then we should treat the tuberculosis for 2 months and assess the response. Exactly how the response is there If the patient shows improvement, we should reassess the patient after 6 months. However, if there is no response or no change is seen on endoscopy at the end of 2 months, then we have to reassess the patient. Reassessment means reassessment with CT angiography, reassessment with endoscopy, reassessment with biopsy, and then we can again think of, are we dealing a case of a Crohn's disease or tuberculosis? Thank you.
Thank you so much, sir, for your thorough investigation of the case and for insightful presentation. Any other diagnosis or question from the audience?
From the regularly, it seems that the liver was quite long segment involved, and this picture and no necrotizing lymph nodes were there, necrotic lymph nodes. So, stage problems will be the first problem. And any possibility of local lymph duration of symptoms is quite long. So, higher lymph node is not possible. Any other local lymph nodes and present.
See, the scenario changes after giving a anti-tubercular treatment to these patients. All these findings which I have enumerated, they may be first assessed. They are in the first imaging what I have told you. So I don't have the first imaging which was done maybe before starting the anti-tubercular treatment to these patients. So it is very difficult to predict, like, because everything changes, like the fibrosis occurs there. We don't have an eccentric technique what has been prescribed in the patient with you can say Crohn's disease. We have a, you can say, a technique which is neural technique which is homogeneous as such. So in my opinion, it's very difficult to differentiate in this patient based on the imaging event too. So in my opinion, it's very difficult to make the diagnosis as such. But of course, when we talk about the diagnosis as such, this time it is maybe a Crohn's or the tuberculosis. Still, I have dilemma exactly how we should go ahead. But since this patient presented with the acute obstruction, so we have to operate this patient because the patient have a history of pain, abdominal distension, and vomiting. So anyhow, we have to operate and relieve the obstruction to this patient. And the treatment which is to be prescribed to this patient is the resection anastomosis, so that we can also have a specimen there for the, we can say, histology, and we can start the treatment, proper treatment post-operatively.
So periodically, actually, it's a long segment involvement. So imaging wise, there's a long segment involvement with maintained fluid structure, and also there was multifocal involvement. And there was some stranding in the abyssal vicinity, and the nodes were also very small and homogeneous. So for us, the first detection would be Crohn's in this case. And the second detection would be ischemia, because it's a very long segment involvement. So these are the two common causes of long segment involvement that we see. So must be right that clinically we would have thought of tuberculosis first.
Can we have a neural technique to that extent in the patient with a vascular insult? What you are talking about?
Yes, we can have. But in this case, there were, we saw celiac yesterday, all the major risks were normal. However, whenever we see such kind of cases, these are the common two differentials that we did. Lymphoma is also very unlikely because this will not have maintained fluid structure. It will be a mass-like and dilation of the bowel. That was also not a possibility.
Yeah.
In the variety of possibilities, can these both cases overlap, like a patient Crohn's disease affecting the tuberculosis?
Yeah, it may be a critical possibility.
Because the patient was given immediately for like 7 months ago, which she took and she became better. So my question is that is there any possibility that
I don't disagree to you. Many times we have a patient where we have done a mastectomy, we get a report that a patient has having a risk carcinoma along with tuberculosis. So it is not uncommon to have a tuberculosis in our setups where it is tuberculosis is endemic. So we may have associated condition, but theoretically it is more of a theoretical rather than practical. If we have a case, of course, we have treated the tuberculosis to the patient. Now we have to treat the disease.
It's the initial stages. Yes, so in the initial stages it can be there, then it becomes highly massive occlusion, then only you will see that non-axial of the body. Otherwise, an embolic event can lead on to this kind of incidents. Thank you, sir. Uh, Now, I would like to invite the treating clinician, Dr. Sushant from surgery, to comment on how they worked up the case.
So we have the history, we have the investigation, and the clinical picture of recurrent subacute obstruction. We decided to wheel in the patient and do a diagnostic laparoscopy first. On entering the abdomen and creating subsequent ports, you could see there was minimal ascites. The liver was grossly normal. There were no mental or peritoneal deposits. However, mesenteric nodes were there. And on further bowel walk, we could see few strictures. One was isolated, and further down, the whole bowel and mesentery was clumped, and it was stuck to the pelvis. This is the first stricture, and the stricture started around 70 to 80 centimeters from the DJ flexure. There was minimal ascites. So there was ascitic fluid in the abdomen. There was clumped bowel wall, and strictures were there. And further down, there were more strictures. So we decided to cut open the abdomen. And because the anatomy was difficult and the ball was stuck, so we decided to cut open the abdomen. And we did a resection anastomosis of the small bowel. Around 30 centimeter of the bowel was resected, and the abdomen was closed.
Thank you, Dr. Sushant. So, as Dr. Ankita has already discussed the radiology part, we can continue with the histopathology. No? So, we received iron dissected segment of a 49-year-old female. This was the requisition form, and according to that, the clinical suspicion were lymphoma and inflammatory bowel disease. So, we received already cut open specimen of dissected iron segment measuring 41 centimeter in length. Serosa appeared unremarkable, and two strictures were identified measuring 1.5 centimeter and 1 centimeter in maximum dimension. The rest of the mucosa showed focal areas of ulceration and congestion, and 12 lymph nodes were identified on serial section of attached fat. So, on the basis of these strictures on gross examination, we considered the differential diagnosis of IMS strictures based on the gross finding. So, these differentials are tuberculosis. So, according to clinical history, patient had already taken treatment for TB. Then Crohn's disease, which was again a differential, pelvic inflammation, ischemia, radiation enteritis, carcinoid infiltration, lymphoma, paralytic ileus, and diffuse enteropathy. So all these are differentials of iron strictures. On microscopy, most of the areas are morphologically unremarkable. However, sections taken from the stricture side showed an infiltrative tumor in the muscularis propria as well as in the submucous. On hyper view, we can see that tumor cells are arranged in nests and cords with retraction artifact. Here we can see that nest of the tumor cells are surrounded by thin capillary channels. Focal glandular differentiation was also noted. These cells were having bland looking round nuclei with fine stipple chromatin, indistinct nucleoli, and moderate amount of eosinophilic cytoplasm. We also found lymphovascular invasion and a lymph metastasis to one lymph node was also noted. On immunohistochemistry, these cells were immunopositive for pancytokeratin and chromogranin. Here we can see enterochromatin cells which are serving as an internal control for chromogranin. Cytophysin was also positive, ISM was positive, and tumor cells were also positive for CDH2, which is a marker of ILH, like to denote ILH. Ki-67 proliferation index was less than 1%. So here we can see that few these endothelial cells are showing immunopositivity for Ki-67. However, the tumor is entirely negative. So on the basis of these histomorphological findings as well as IHC findings, a final diagnosis of well-differentiated neuroendocrine tumor WHO grade 1 was made, and pathological stage was PT3 as tumor was infiltrating the perimuscular connective tissue without infiltrating the serosa, and one lymph node was positive, that is by PN1, and stage 2 was 3. Now, brief introduction of neuroendocrine tumors. These are heterogeneous group of malignancies, and the term neuroendocrine is applied to widely dispersed cells with neuro and endocrine properties. Now, the neuro property is based on the identification of dense core granules that are similar to dense core granules present in the serotonergic neurons which store monoamines. However, these cells do not have synapses. The endocrine property refers to the synthesis and secretion of these monoamines. The neuroendocrine system includes endocrine glands such as pituitary, parathyroid, and neuroendocrine part of adrenal gland. Then endocrine islets, tissue embedded within the glandular tissue like in thyroid and pancreatic tissue. Then we can also see scattered cells in the exocrine parenchyma, such as endocrine cells of digestive or respiratory system, which is known as diffuse endocrine system. Neuroendocrine tumors, small intestine, are extremely rare, accounting for just 1 to 3% of GI tract cancer. But now, consequently, these tumors have now become the most common GI neuroendocrine tumor and have recently become more prevalent as compared to adenocarcinomas. Jejunal endocrine tumors consist of enterochromatin cells that liberate serotonin, and these tumors are ileum and jejunum are the most common site, accounting for around 28% of all NETs. Patients between the age of 50 and 64 have high prevalence. Males are slightly more affected than females, and an annual incidence of 4 to 5 cases per lakh individuals. The clinical presentation, so most patients of GI neuroendocrine tumors are non-functioning tumors with subtle or no symptoms. They become clinically active because of the mass, like if there is any intestinal obstruction or jaundice. But approximately 30% of the patients may present with symptoms of carcinoid syndrome, and these symptoms are diarrhea, bronchial obstruction, flushing, palpitation, and intermittent hypertension. And these symptoms are induced by hypersecretion of serotonin, which is and other bioactive substances from tumor. Now, this carcinoid syndrome is more common in patients and neuroendocrine patients with neuroendocrine tumor with liver metastasis because of the capacity of the liver to inactivate these bioactive substances into the portal circulation. Jejunal and ileal NETs may lead to intermittent abdominal pain and can present as intermittent obstruction or small bowel ischemia. So, in our case, the clinical morphological diagnosis was not that difficult, but the clinical scenario and gross presentation was extremely rare. So, literature search to be few similar case reports where neuroendocrine tumor presented with the findings of intestinal obstruction. Like in this case, the patient presented with the features of intestinal obstruction due to mid-ileal stricture. Another case series, 4 patients had carcinoid tumors of the terminal ileum that were diagnosed with Crohn's disease and were treated for that. In one more case report, we found that 56-year-old male presented with the symptoms of intermittent bowel obstruction and long history of recurrent bowel obstruction. But a neuroendocrine tumor presented with stricture without any mass is extremely rare, like in our case. The pathologist Oberndorfer invented the word carcinoid at the turn of 20th century, and because so carcinoid means carcinoma, which denotes the benign behavior of morphologically atypical small bowel tumor, which composed of argentophin positive and agarinophilic cells. Why we call them argentophin positive? Because they take up and reduce silver salts. So the word carcinoid has been criticized later as an because this word it's an imprecise, generic, non-user friendly word and obsolete capture the lungs to get a different tumor entity which has different etiology, prognosis, and management, and it can create confusion and diagnostic unreliability. Another cause is it's a straight misnomer because despite the presence of innocuous appearing cells with uniform nuclei and few mitosis, these tumors these tumors can behave differently, and metastasis in local invasion is known, and recurrence is also common in these tumors. According to the fifth edition of digestive system tumor classification, this is the latest one, neuroendocrine tumor of small intestine and ampulla are subcategorized into three categories. These categories are neuroendocrine tumor NOS, neuroendocrine carcinoma NOS, and mixed neuroendocrine non-neuroendocrine neoplasm. Now the pathological features, so grossly mucosa is often intact with the tumor, infiltration of the submucosa is the root, and extension into the muscularis propria is formed. For the formal fixation, the tumor has a bright yellow color, which is not that evident of fresh tissue sample. On microscopy, tumor can present as solid nest of monoclonal appearing cells along with glandular differentiation or trabecular are also common, with moderate amount of finely granular cytoplasm, small nuclei with fine stipple chromatin, which we call as salt and pepper chromatin, indistinct nuclei. Extensive fibrosis is very common, that is mesenteric fibrosis is very common because of production of serotonin. Lymphovascular invasion is also common, and in some cases, mucosa surrounding the tumor may contain highly vascularized polypoid formation that can simulate Crohn's disease. And non-neoplastic mucosa may also show hyperplasia of the endocrine cells. So there are two parameters for this WHO classification. These are Ki-67 proliferation index and mitotic index to classify these tumors. For well-differentiated neuroendocrine tumors, if the mitotic count is less than 2 per kilogram square and Ki-67 proliferation index is less than 3, the tumor is categorized as NET grade 1. For NET grade 2, Ki-67 index should be 3 to 20 and mitotic index should be at 2 to 20 per kilogram square. NET grade 3 will show Ki-67 index more than 20 and mitotic count of more than 20. Poorly differentiated neuroendocrine neoplasm, also known as neuroendocrine carcinoma grade 3, and subdivided into small cell type and large cell type. And for criteria for these tumors, the Ki-67 again should be more than 20% and mitotic index should be more than 20 per 2 mm square. Now, chromogranin A, synaptophysin, and IMS, these are few markers for neuroendocrine origin. Among these markers, synaptophysin and IMS1 are most sensitive. Neuroendocrine neoplasm are more likely to express CK8 and 18 than CK7. And iron serotonin producing NETs can show positivity for CDX2 as well as for SSTR2. So, if there is absent RB1 and aberrant p53 expression, this can be helpful in making a diagnosis of neuroendocrine carcinoma when neuroendocrine tumor grade 3 is a differential. SSTR2A IC may be useful to select patients with metastatic disease or metastatic analog therapy. So, it is not that difficult to make a diagnosis of neuroendocrine tumor based on the markers of origin. But the main dilemma, main problem is determining the origin of neuroendocrine tumor in the cases of metastatic disease. Because the treatment for all these entities varies from site to site. So there are few immunohistochemical markers which can be helpful, like DATA3, which can show immunopositivity in cases of paraganglioma, pheochromocytoma, and absent expression in epithelial neuroendocrine neoplasm. However, neuroendocrine carcinomas can show variable positivity. Pituitary neuroendocrine tumors can show positivity for PIT1, TP10, and SF1. Then TTF1 is a marker for pulmonary neuroendocrine origin. TTF1 and CEA can show positive immunoexpression in medullary thyroid carcinoma. Then a panel of ISL1, PDX1, and CDX2. So they suggest NETs arising from the small bowel and pancreas. SAP2 suggests the origin from lung. So a comprehensive immunohistochemical panel comprising of four markers, TTR1, CDX2, ISL1, and PDX1 can help in differentiating these entities. So if the tumor is TTR1 positive and negative for all markers, it supports a diagnosis of pulmonary neoplasm. If the tumor is diffusely positive for CDX2 and all other markers are negative, it suggests a mid-cut origin, usually from iron or appendiceal neoplasm. Then if TTF1 is negative and weak or negative expression is there for CDX2 and ISL1, but PDX1 is positive, it suggests a neuroendocrine neoplasm originating from pancreas or duodenum. There are few other biomarkers like loss of ATRX, DAX, menin, P27, and retained expression of SSTR2 and 5 used to support the diagnosis of neuroendocrine tumor grade 3. If there is global loss of RB and diffuse positivity or total loss of P53 with loss of SSTR2 or 5, it supports the diagnosis of neuroendocrine carcinoma. There are a few prognostic IHC markers like CK19, which is an independent prognostic factor with a 5-year survival of 100% for all CK19 negative cases. IHC is correlated with more malignant behavior and with greater propensity to metastasize. And CK is also associated with adverse prognosis, loss of expression of DAX and ATRX to be associated with more aggressive behavior and shorter disease-free survival. In our case, P53 was wild type, whereas ATRX and RB1 were retained, which suggests the diagnosis of low-grade neuroendocrine tumor. Now, as we saw that the criteria to differentiate neuroendocrine tumor grade 3 and neuroendocrine carcinoma are same, that is Ki-67 proliferation index of more than 20% and magnetic count of more than 20. There are some morphological clues and IHC markers which can help in differentiating these two entities. Like if you are getting abundant necrosis, abundant fibrostoma, severe cellular pleomorphism, then high MC ratio, and frequent mitosis along with atypical mitotic figures, and these hormonal profiles are negative. Hormonal profile is negative. SSTR2 can be variable or negative or positive, and then Ki-67, very high Ki-67, typically more than 55%, with global loss or diffuse positivity for P53 and global loss of RBG. All these features suggest favor the diagnosis of neuroendocrine carcinoma or neuroendocrine tumor grade 3. Now we were talking about the functionality of the tumors. The question is whether the functional characterization of gut neuroendocrine tumors is relevant or not. A wide variety of peptide hormones are expressed in tumors. In these tumors, like serotonin, substance P, gastrin, glucagon, and other peptides. All these markers have limited clinical usefulness because hormonal expression by immunohistochemistry does not correlate with the functionality of the tumor. Furthermore, these markers are expensive and time-consuming analysis of these markers, but there are certain scenarios where we should use these hormonal profiles. Where if there is hormonal function assessment, may by itself be prognostic informative, like insulin-producing tumors carry more favorable prognosis as compared to other functional and non-functional tumors. If hormonal profile function of metastatic cases may be suggestive or confirmative of their primary site. And syndromic tumors, a correlation between ISA findings and serum biochemical parameters can help in ascertain the source of syndrome. Assessment of hormonal tumor profile along with the tumor biomarkers may indicate factors to be preferentially monitored for early diagnosis of possible tumor recurrence. So we also did few markers which were available, few hormonal markers. Tumor cells were negative for insulin, metastatic, glucagon, and gastrin. All markers were negative. The molecular profile, so small intestinal neuroendocrine tumors have a complex genomic landscape. Approximately 60 to 90% of jejunal and NETs show chromosome 18 deletion, and the mutation of CDK and 1B are found in less than 10% of IML entities. Now, how to diagnose and work up these cases? So, hormonal profile at IC level is not that significant, but evaluation of circulating biomarkers at the time of first diagnosis and as a baseline assessment at the time of starting a new treatment is recommended. There are certain markers which can be evaluated, like chromogranin 1. So, the level of chromogranin 1 in untreated small intestine neuroendocrine tumor can be correlated with the tumor burden. However, this chromogranin A level cannot be used as a screening test because there are chances of false positivity in certain non-malignant diseases like impaired liver function test, kidney function test, atrophic gastritis, or inflammatory bowel disease. Then another marker is 5-hydroxyindolistic acid, which is a metabolite of serotonin, and plasma and serum level of this marker has become increasingly used in the clinic. Then impaired kidney function test is another factor which can influence the findings, which should be taken into consideration. Then tachycardia circulating levels correlate to flushing and bronchospasm in cases of carcinoma. In patients with carcinoid heart disease, measurement of N-terminal pro-brain natriuretic peptide can be helpful to assess the degree of heart failure and should be monitored regularly. According to a scientific report presented by Fries et al., they found that if the patient has increased level of aspartic aminotransferase and LDHs, the survival is more as compared to the patient with low LDH and AST level, and they suggested that considering LDH and AST levels at diagnosis could be helpful for the physician to predict the survival and triaging the patients for clinical trials. So, what is the role of imaging? So, for CT or MRI contrast enhancement is recommended as initial staging investigation. Somatostatin receptor imaging with PET-CT or PET-MRI is recommended for the diagnostic workup and staging. And more aggressive phenotype, if the tumor is having 67 proliferation index, then high FDG uptake has been seen. And that FDG uptake is highly prognostic around all the neuroendocrine tumor groups. MRI using contrast is the best method to assess the liver metastasis. So this is the diagnostic algorithm for the patients with small intestine neuroendocrine tumor. So once the patients have clinical symptoms of carcinoid syndrome, then first biochemical assessment should be done and ultrasound of CT should be done to look for the liver or lymph node metastasis. If liver metastasis is there, then liver MRI is recommended, and if biochemical tests are positive, the patient should be screened for carcinoid heart disease by using NT-proBNP and echocardiogram. If the tumor is detected on colonoscopy with for bleeding, diarrhea, bowel obstruction, or screening endoscopy, and a tumor is detected at terminal IU or ileocecal lesion, after taking a pathological diagnosis, again, liver metastasis should be screened by using CT or ultrasound, and then somatostatin receptor imaging should be done along with PET. If the tumor is incidentally detected on imaging by CT or mesothelial lymph node and liver metastasis, then again, first of all, it is very important to evaluate for carcinoid syndrome, and after doing biochemical assessment, biopsy of liver metastasis or mesothelial lymph node is recommended. Now the treatment part. So the patients suffering from carcinoid syndrome are treated differently from patients with non-functioning SIMP. So the treatment for both functional as well as non-functional tumor are different. So first of all, the thing which is very important to control carcinoid syndrome, which should be a priority before any procedure, any surgical procedure to avoid carcinoid crisis. And the mainstay for the treatment of carcinoid syndrome is long-acting somatostatin analog, and with the disease is unresectable, then also we can give long-acting somatostatin analogs. Hepatic resection is also recommended. So, where liver metastasis, 90% more disease bulk can be resected, keeping adequate functional hepatic reserve. Then role of surgery. So all localized resectable SIMTs should be operated because that is the only chance for long-term cure given the high rate of lymph node metastasis, even if the tumor is less than 10 mm. A recent systemic review showed that 90 days mortality after the surgery for these tumors is highly low outcome center as compared to higher volume hospitals. And these tumors are frequently associated with mesenteric fibrosis, which might cause bowel obstruction and ischemia. And these patients also have significantly poor survival. So surgery remains the cornerstone of treatment in patients who report symptoms related to mesenteric fibrosis, such as abdominal pain or present with the bowel obstruction. There are a few other treatment modalities like radionuclide therapy, everolimus, tyrosine kinase inhibitor, and chemotherapy. Immunotherapy approaches in these tumors have been disappointing, and monotherapy with immune checkpoint inhibitors has not shown much activity. So this is an algorithm for treatment approach of these patients. So prior to any surgery, prophylaxis for carcinoma crisis should be given, and then after confirming the diagnosis pathologically, if the tumor is localized and patient is fit for surgery, then resection of the tumor should be done irrespective of the size, and then follow-up can be given. Then, if metastatic disease is there, but patient is fit for surgery, then that tumor is resectable. Then, the second most thing which is very important to know is liver metastasis. If simple pattern of liver metastasis is there, then one surgery can be done for both primary as well as metastatic resection. And when complex pattern of liver metastasis is there, then two-step surgery should be given. And if the tumor is not resectable, then systemic treatment is the option. For grade 1 tumor, if the tumor is asymptomatic with no tumor burden, waiting watch policy can be adopted in certain circumstances. For grade 1 and grade 2 tumor with Ki67 up to 10%, and somatostatin is positive, then somatostatin analog can be given, and if it is negative, then everolimus and alpha can be given, and novel TKI therapies are still under trial. For grade 2 tumor with Ki67 index more than 10%, everolimus, novel TKI, TRRT, and chemotherapy can be given. And for grade 3 tumors, various clinical trials are ongoing for TRRT, chemotherapy, and everolimus in selected patients. Now, the prognosis of entities these tumors have indolent natural history. Early stage entities of all anatomical sites have no risk of metastasis if they are entirely removed. Larger or higher grade entities can metastasize and are difficult to treat, but the overall survival is still lower as compared to other tumors. And patients with small intestine entities often present with metastatic disease and nodal metastasis, mesenteric involvement, lymphovascular invasion, perineal invasion, high 67 index, all of these have a high risk of. So, in a population-based retrospective study done by you et al., adjusting incidence of 30 SIMTs was 1.3 per upper lakh population, and the tumor are most commonly located in the eye and small size was smaller than 2 centimeter. The 5 and 10-year cancer-specific survival rate was 95% and 88.5% respectively. So this suggested that early SNETs have favorable prognosis. Surgical resection may improve the outcome, particularly in older patients and those with larger tumor size. So the recommended follow-up after surgery, every 3 to 6 months follow-up imaging follow-up should be done. Imaging follow-up in palliative setting after the first assessment at 3 months from starting a new treatment, imaging every 6 months is recommended, and biomarker follow-up should also be done like chromogranin, NSC, and 5-HIA at the time of first diagnosis as a baseline assessment, and at the time of starting the new treatment. So, overall diagnosis and management of small intestine neuroendocrine tumors requires specialized multidisciplinary team approach. A differential diagnosis of NET should be kept if the patient presents with long history of intermittent bowel obstruction, and in cases of GI strictures, extensive sampling is very important to not miss the NET infiltration, and the biomarkers can be used to guide diagnosis, follow up after curative management, and to monitor the treatment response of SIMPs. At that, I want to acknowledge all my pathology team and special mention of Dr. Prasanjit Das and Dr. Rajni Yadav, who are GI pathologists in charge of GI pathology. Ma'am has primarily reported the case. Dr. Sandeep Madhav sir for helping in immunohistochemistry. Dr. Achal Katkar ma'am for arranging all for doing all the arrangement for CPC. My SR Dr. Sunil and Mr. Pramod, who is our technical in charge of IMS. Thank you.
But Sonali, I have two questions. What was the size of the tumor and did you find the tumor at the site of the which strictures? At the site of stricture or
Tumor was there at the site of stricture. So two strictures were there, and tumor was there at the site. Both the strictures were having tumor. Grossly, there was no tumor, no growth.
and what is the status? Because non-segment involvement, thickening, what is the status of the distance?
Yes,
The patient or remove. There may not be tumor stricture or any chronicity which
so focal ulceration was
what is changed because in also show the loss
congestion. So focal ulceration and congestion was there, and at the site of tumor, mucosa was focally ulcerated, and the rest of the mucosa was morphologically.
So section actually came in both the sectors. When I went back to see the specimen, I thought there would be leftover tumor. And then I saw the specimen, so every week of there was actually so it was being so fine. So I was actually surprised and shocked that section had tumor and this is of the patient only. So we took extra sections from the site he had done. He also didn't see tumor. So there were very nice sharp sections. And when we took the more sections, we didn't get extra. So that whatever came was in the first, we couldn't measure also. We measured macroscopically then. Because grossly we couldn't make. And the mucosa away from that, it was very nice. It was become very clean, neat, very sharp and become sharp. We can see it gone. But the mucosa was fine. Which is lucky since it has picked up and stayed at the site. So there are no great safety and bacteria.
Lymphoid metastasis. So tumor was there at the site of stricture.
So multiple sites. So the small intestine sizes are known to be very, very small, even when the metastases are becoming with the liver and all very huge. And like I think radiologists can so sometimes people ultrasound and see the whole gut and then find the size like 1 centimeter and metastasis is 3 centimeters. Yeah, they can be multiple.
So,
Only two strictures were there.
Anyway, they have told like 3 strictures, but we got 2 strictures. Yeah, it was very unusual.
This is very unusual for because when tumor is there, usually there was a small so mass really rapidly. The histoplastic reaction that was happening on that you really if I could diagnose it effectively, I will not be able to. But if you tell me that this is neuroendocrine, I will be yes, you easily the same issue. So if we can go back, this can continue and there are these reports of carcinoid presenting with long segmental wall. Prospectively, it is very difficult to say.
So I want to make a copy of the rare class we never is very rare. You might so what we are talking about is most of these patients they have because of the thinking of the bowel under the patient they have a symptomatic reaction leading to a fibrosis that is usually leading to the thinking of the bowel. So most of the patients want to get upper carcinoma because of the thinking of the bowel rather than the structure of the bowel which has been presented to us. So that is very unusual to have a structure of the bowel. The next thing I want to emphasize here, if we get this is a patient with a grade 1, you can say, tumor, which is microtic index, AKI 67 is less than 1%. So just you have to wait and watch. Because if you want to evaluate quickly, we talk about the evaluation of the effect along with the same receptors, what you have talked about. And they are both supplementary to each other because what happens the high-grade tumors they take the effect along if we talk about the somatostic receptors scintigraphy or we can talk about the newer modality that is nowadays, which is been done, that is basically meant for a well-differentiated tumor. So both are recommended in the same patient. Because when we talk about the big effect, they are positive, they are high-grade tumors. They are well-differentiated tumor, you can say positive. So this is the way exactly how we manage these patients and concentrate for having a rare diagnosis. Thank you.
But Dr. Puneet, still I will ask you, do you think it's clinically fitting because the patient had history of 3 years, right? 6 years?
It's all because of the reason. See, as a clinician, what you coaching? As a clinician, you have to pick up common things. Although the way is not there on this topic, but as a clinician, we always emphasize that we should always pick up a common thing what we get in of a neuroendocrine. We have done a lot on this topic how to be AIIMS. Thank you.
Invite the treating clinician to comment on further management.
Actually, this patient was apparently doing well for the first 4-5 days. Then she developed actually acute abdomen on the 7th day. So we had to re-explore her, and we found almost 20-25 centimeter of ischemic gut inside. And unfortunately, we lost the patient actually because of the ischemia. So I think so. Maybe now thinking retrospectively, carcinoid syndrome causing. Actually, if you see the laparoscopy and the images, there was a lot of mesenteric thickening in that. The bones were literally clumped together in the mesentery. So retrospectively thinking, maybe that was one of the, because we were also surprised why should this patient should have a gut ischemia, because section anastomosis for tubercular or Crohn's disease, when a patient usually recover, they go home third, fourth day. But this patient developing ischemia, leak, and then sepsis was very unusual. So maybe there's another finding that maybe adds to the diagnosis that we. Yeah, we came to know the diagnosis came up. At first, that was surprising. Then only we thought, okay, maybe that's a carcinoid syndrome. Because I was thinking maybe was it a technical issue? Because all of us are doing the same thing, and was it some technical issue? Was it patient related? But maybe thinking about that, we went in and saw the literature that yes, gut ischemia is possible in carcinoid syndromes. So maybe then we retrospectively thought that that might be the reason for the gut ischemia. Maybe. Thank you very much. And I think it was a great discussion. I'd like to thank Dr. Puneet for accepting our invitation to come and present this. Thank you very much.